So hello everybody and welcome to our second ever DSN Forum brunch. This morning we have NHS England with us. We have Jonathan Bludgy and Parth Carr. So I think it's quite an informal sort of chat, so please do put in all your questions. We do have a few already from the forum that we're going to ask our two wise men, because this is Christmas themed, obviously, because it's nearly Christmas. So
I don't think we've ever been called that before.
Well, there's always a first. DSM Forum would like to be the first in things. So yeah, I think I'll let you two introduce yourselves. So Jonathan.
Hi everybody, good morning. Jonathan Bludgy, I'm the National Clinical Director for Diabetes and Obesity and consultant diabetologist at Imperial in West London.
And Partha?
Partha Carr, National Specialty Advisor, Diabetes with NHS England and Consultant Diabetes in Portsmouth.
I think, you know, the team, we're always on social media. My name's Amanda. I'm a diabetes specialist nurse at Medway NHS Foundation Trust in Kent. Beth?
I'm Beth. I'm Beth Kelly, a DSN down in Southampton City.
Tamsin?
And I'm Tamsin. I'm a diabetes specialist nurse at the Royal State University Hospital.
And we're missing our fourth friend in the DSN Forum, Vicky Alabarbara, who is the Diabetes Healthcare Professional of the Year currently for the QIC. But she is busy working this morning, so she's going to send us her questions in between patients, hopefully. So I'm going to start with an icebreaker. And because it's Christmas, I'm going to ask you, Jonathan, first, what is your favourite Christmas film?
I can't get the Wizard of Oz out of my brain when I think of Christmas films. Everyone shakes their head and thinks, what's he talking about? But that's what I remember as a kid. There's a risk I'm showing my age there.
Was it in black and white? Then
it started in black and white. No. Went into colour after a bit.
Partha, what's your favourite Christmas film?
Oh, many choices. I mean, I think, you know, obviously, you know, expectation would be I would say something like Die Hard. Die Hard is a lovely Christmas film, you know, gentle and relaxed. But I think Elf. I really like Elf, so it makes me always laugh, and I would definitely probably pick that as my favorite Christmas film.
Tamsin, what's yours?
Oh gosh, you just put me on the spot now. Groundhog Day.
Go to Beth first. Sorry.
no, it's all right. Groundhog Day. That just makes me laugh quite a lot, and it's like snowy and Christmassy, and yeah. So
I'd have to pick Home Alone. I think definitely a favourite of mine. Yeah.
Mine's Love Actually, because I'm a hopeless romantic. There you go.
Yeah.
And the holidays is quite second, you know. Yeah. Okay, so let's get to the proper questions. As much as we love talking about Christmas. So there's a few questions that we got from the forum, but I think, should we start by you saying what kind of things have happened this year in terms of diabetes care? Like, what are your achievements for this year? What have we seen? And considering we've had COVID and a lot of things have had to stop, has there been lots of achievements this year, or are we sort of got things on hold until next year? Or
Shall I go first, Partha?
Yeah, go for it.
Yeah, it's been a year that none of us would have anticipated 12 months ago, I suppose. Really challenging for everybody, societally, people with diabetes, healthcare professionals, and obviously often with, unfortunately, tragic consequences for some people with diabetes. Lots of people actually, but a high proportion of people did have diabetes, unfortunately, who passed away with COVID. But it's had huge impact, I think, on everything we do, probably all five of us on this call. So I think things were going very well in the diabetes programme in NHS England, both the sort of treatment and care work streams, the type 2 diabetes prevention programme, and I think we were on schedule to achieve our milestones. Things were going very well, and everything changed. And I think I think the important point was the way in which we had to adapt really rapidly. Just using the type 2 diabetes prevention program as an example, but of course, lots of what we do in terms of empowerment in diabetes care as well as diabetes prevention is sort of group-based, face-to-face, and that instantly became not possible because of social distancing. And so the adapting of programs was very important. We achieved that in the diabetes prevention program in about 2 to 3 weeks. Actually, the providers adapted, but it became clear very quickly that all sorts of other aspects of care couldn't take place. We know as healthcare professionals ourselves that much of the sort of outpatient clinical interaction became remote, still is remote, and will probably have some degree of lasting impact on our practice in the longer term. But we undertook some rapid procurements to get more availability and access to online modes of sort of supporting self-management in both the type 1 and the type 2 space. I think one of the early things we did was we tried to provide clarity really for the diabetes community as to what COVID meant, and it really wasn't very clear. There were early signals that people with diabetes were overrepresented in the people with the sort of most severe outcomes of COVID. But the fantastic data that we have in England paved the way really for us, and we moved as quickly as we could. I think we moved fairly rapidly, and by mid-May, we had 2 papers that we put out as preprints and subsequently published in Lancet Diabetes and Endocrinology that actually probably gave the sort of definitive evidence, if you like, of what the impact of COVID was for people with diabetes, both in terms of the added risk of severe outcomes, in particular, sort of the added risk of dying of COVID, but also within the cohorts, people with type 1 diabetes, people with type 2 diabetes, we were also able to disentangle the factors that predicted worse outcomes. And importantly, for both types of diabetes, interestingly, we saw emerge, the importance of HbA1c and also the importance of body mass index, actually, and the impact of obesity in sort of increasing those risks, even though we're not used to obviously talking about obesity in the type 1 diabetes space. Obesity was an important determinant in the type 1 diabetes population as well. And that paved the way for us to sort of plan our strategy really over the ensuing months. And hopefully we've done that as effectively as we could, but there's still, we're not out of this yet, are we? And there's still lots to do, but there we are, I've talked enough. Partha, your turn.
Yeah, I mean, I think you've summarized it in the sense that, we've done a fair few things, but a lot of it has been, we have had to adapt to the present times. I suspect big things have been, we have been able to restart again the CGM in pregnancy work, which was obviously put on hold after the first wave hit. I think finishing the Libra work, that was quite good. And then moving on to the next phases as we talk about technology. I think the education platforms for type 1 and type 2, they're also good steps. So in one way, I suspect the COVID-19 has accelerated some of our programs and work because of the necessity of it all. And I think the GERF report coming out was also quite good. So lots of things have happened in the diabetes space. It's now a question of, when the dust settles, when hopefully the vaccine program takes off and everything, how do the diabetes services look like? And that's going to probably be a challenge going forward. So I think as a team, we're quite, I would say, proud of a lot of the things we have done. We've always looked back at, sessions like these and asked our colleagues across the country, as well as people living with diabetes, so what else could we do differently? What areas we could focus on? So I personally feel that these things are also quite relevant, these talks, because the feedback we get does form, or we try to at least take as much we can take into account in making those changes. So yeah, that's what I would say.
Yeah, I think it was really helpful to us in the early days when NHS England were coming out with all of the guidance and things. So because people were scared when we were seeing that on the 101 account, social media was really, really busy with people asking questions about, am I going to die of COVID? It was quite a scary time. We do have some questions from Facebook. So I might get one of the girls to read one of those out. Beth, do you want to go first and read one of the questions out?
Yeah, so I think one of the big things which I know is always a struggle in our service as well, and possibly all of us think this, I'm not necessarily sure it's a problem for you two to solve yourself, but the question of joined up IT systems and how sort of primary and secondary care and tertiary care can all sort of communicate with each other. Is there any sort of plans for you guys to maybe tackle that as in diabetes care next year or in the future?
So I'll take a bit of that and then Jonathan can pitch it. I think there are two aspects here. One is, do we do something individually for diabetes, which would be probably difficult to do, given that, you know, if you want to tie it in with primary care, we need it across the board. We can't just have an IT system just for people with diabetes, given that, as you all know, lots of people with diabetes don't just have diabetes. But there is a lot of focus and pressure, I would say, for data sharing, both within clinicians and from people living with any condition, so to speak. And one of the pieces of work that we just started is on things like data interoperability. So how does data share across systems? And yes, we are doing that for people with diabetes, but we expect that to go much wider because, you know, ideally you want, I mean, let's be honest, as you know, I'm sure as clinicians, what would you like? You'd like to go into work and have one platform where you open up and you can see everything, right? That's what you want to know. You want to know what the general practitioner has done, what the retinal screen has been, where has the foot check been done, how many cares, you know, you want everything in one. That's the holy grail, right? And I think there's a lot of work going on, but, and I'm sure Jonathan can have a view, but it's always been a issue for the NHS trying to crack that, simply because I think historically, from what I've gathered, we don't have the data sharing agreements with the companies. And we know that with technology companies, don't we? You know, when we sit down in our tech clinics, you know, Medtronic have got one, and Dexcom have got one, and Abbott have got one, and we're sitting there going like, why can't you all have it in one place so we can do it properly? And that's just a simple example, isn't it? So, yeah, so that is a big challenge. But I think there's a wide piece of work in NHS going on about. There's a lot of focus. That's why NHSX and all these things have been developed, to be honest. So, yeah.
That's interesting.
I think Path has captured all of that, really. I can't remember, it was one of our diabetes boards in maybe September time, August, September time. We have actually started the work, made some initial sort of investment to support the initiation of the work, as it were, to try to develop those common standards, data standards, which I think be really important. You know, just to reiterate, you know, sitting in our type 1 diabetes clinics, having to log on to 3 different systems, we all find frustrating and a little time consuming, don't we? So if maybe that's aspirational, but if we could get around that, that would, I think, be helpful to all of us. But I think it would also be helpful to the system and care in the longer term as well, if we could have that interoperability, really. But let's see how we go.
I think COVID has probably sped up those kind of things, hasn't
it?
People are thinking we need this to work properly. You know, in our hospital, we still have paper notes, and you know, you have to go into the hospital to be able to do a clinic because you've got no access to the notes otherwise. But in the GP surgeries that I work in, everything's online and you can see everything, and I can do it all from home. So there's I don't have to go into 9 different GP surgeries now. So it's we definitely need better IT systems in the whole of the NHS, not just in diabetes. So there's some more questions. Tamsin, have you got one there from Facebook?
Yeah, so I mean, I think we probably see both on our Facebook page, but also on social media with people with diabetes, that there's still the postcode lottery when it comes to accessing, you know, technology, pumps, Libra, those sort of things. And how are we going to move forward in 2021 to try and make it less of a postcode lottery for those people?
So shall I go, Jonathan, first?
Please do, yeah. Go on, Partha.
I think there are 3 separate problems, if I'm very honest, and all 3 of them got slightly different angles to it. Let's take pumps. So pumps should not have a postcode lottery because they're under a technology appraisal. It's funded. If you've got a pathway, you should have it, right? And what we found from the GERF piece of work was not down to CCGs. That postcode lottery, for want of a better word, was due to probably clinicians' level of engagement. Some people feeling that they didn't see pumps being a fundamental part of type 1 diabetes care. Some people feeling, so for example, if you go to, let's say you take Jonathan's Hospital, Imperial, go to Guy's, really high uptake where we are, and then we go to X, Y, and Z where it isn't. So, which is why the education platform has been built, and part of the GIRFT work and our national work is to make sure that there is a more uniform uptake. So I think pumps are a different debate as to postcode lottery. So if you fit the criteria, you should really have it. That's pretty much pumps. With Libra, I think, you know, as far as our minimal commitment goes, we have achieved that across the board. And I think there isn't, to the criteria, there isn't a postcode lottery. You're absolutely right about people going beyond the criteria. And some centers have done that, where they've gone, which is why the uptake is much, much higher. I again go back to the local clinician side of things. And this is where networks come into play, because we can't step in and mandate everything, because there is a big ask for localism at the same time. People want to do their own things. So it's a balance of trying to do as much as we can from center. So that's the Libra. I think the big challenge is with continuous glucose monitors, and I accept that. And I think what would be good is for probably as evidence space evolves, all the systems being reviewed, because the future is going to be with artificial pancreas and all that sort of stuff. So that is going to be a challenge. And this is where we hope to be working with NICE to make sure that the whole system is appraised. You know, they have done, we got the closed loop system appraisal. The last one was done probably in 2014, which was the Medtronic one in those days. Or was it 2016, which was the, I think the 640G. And we now moved on, right, to the 780 and another one. So I think that's where we need to get to, where we ask NICE to appraise the whole technology space of diabetes. And because that's the power which gives you to open up, because that's what we could do for policy, you see. And I think people, and as I always say to people, there's that balance between NICE's job is to assess the evidence. Our job is to try and put into place the evidence that they recommend. That's the way the equation works. We have done something different in the Libra space, but that's probably because more of the situation as it was. But generally speaking, the idea would be NICE says X, and we try and implement that X across the board without variation. So without variation is our you know, role. So that's what we would try and do. So going back to that, we have done that with Libra. We definitely want to do that with pumps. And if the technology is appraised accordingly, then the next stage will be continuous glucose monitors and pancreas and all this sort of stuff.
Yeah, absolutely. Oh, sorry. Go on.
No, you go.
No, I think Partha's captured that. I think, and really, yeah, Partha has championed the cause for Libra fantastically, and hats off to those achievements. We've now got, when we last looked, and we're probably a little bit higher now, because this was a quarter ago, as it were, 3 months or so ago, you know, we'd hit 31% of the entire type 1 diabetes population had accessed Libra when we last looked. When you say postcode lottery, I think that suggests that has come to suggest sort of difficulties with funding flows, etc., and differentials across the country. But I think we should really remember that there are inequities in terms of access to technologies aside funding. So even if all of the funding is available for everyone eligible, and we saw this with Libra when we started our sort of 2-year work stream well, our intention was to sort of level up across the country in terms of that access. And I think we've achieved that in terms of the geographical access. But what was very clear was the inequalities of access according to socioeconomic status, for example. That appears to be narrowing with the Libra, and that's, I think, you know, due to great efforts by all the teams up and down the countries and different areas and GP systems, you know, networks, etc. But we mustn't forget that. And I think certainly for those of us, and probably all sit more at the secondary care end of care than the primary care end, we look to do the best we can for the people in front of us, and moving to a situation where specialist teams feel that sort of, I think many do, don't get me wrong, but the sense of responsibility for the entire population, even those that haven't been referred up to our clinics, is where we need to get to, because there are a proportion, we're usually talking about technology in terms of its application and support for type 1 diabetes. I think we need to be exploring the sort of horizontal diffusion to the type 2 diabetes population in the longer term as well. But if we confine ourselves to the type 1 population, there probably are, you know, there are a good sort of 15–20% who don't attend secondary care. And so I think we need to be thinking at population level how we make that equity of access, not just from the geographical perspective, but from the equality of access for those technologies as well. Apologies if that seems a bit of a rant, I hope not.
No, it's fine. I think talking about, we do talk about type 1 diabetes a lot, don't we? We've got quite a few questions about type 2 diabetes. I think Beth has one about the obesity work stream and things.
Yeah, just one for Jonathan probably. Obviously we saw Saxenda now been licensed for obesity. So just, we know that we've got the tiered system, but is that looking at being changed at all for people with obesity? There seems to be a big push for, you know, better understanding around obesity and things. I definitely would think in the last year, and I'm seeing a lot more, I don't know what the word, like work around it, especially on Twitter and things with AB and that kind of stuff, Tarani. So just if there's any, you know, going to be any change or work in the next couple of years with that.
Yes, I think there are a lot of opportunities in the obesity space now. If I look back, I've been knocking around as National Clinical Director now for almost 8 years. And when I started, we didn't have a diabetes program or a team or work streams. And I think we've developed over those 8 years, and each opportunity for new investment, new funding, from a national team perspective, that is, I think we've done well to make the most of those opportunities and expand our workings. And we now have a very broad portfolio within the diabetes space. Important parts of that are intricately entwined to obesity management. The NHS Diabetes Prevention Programme is the first in the world to achieve national geographical coverage. We've had well over 600,000 people referred in now, and it's a weight loss program. It's a type 2 diabetes prevention program because of the entry criteria to get in, which is based on a sugar level, but it's a weight loss program. Similarly, you'll be aware that we launched, it was delayed actually because of COVID, the launch by about 6 months, but we launched in September our low calorie diet program to achieve type 2 diabetes remission for those more recently diagnosed within the last 6 years, etc. But that's a lead-in really to make the point that the sort of last funding opportunity, the long-term plan, was the articulation of how we would administer the sort of additional 20 billion that was promised, if you recall, by Theresa May over 2 years ago now, isn't it? And in the long-term plan, we evolved an additional work stream dedicated to prevention and within prevention obesity. And so we now have a dedicated funding stream team and sort of evolving work streams. We've just completed, or we're almost there with a procurement for a dedicated weight loss program. It's been adapted. It's digital. Actually, it's something called the digital digital weight management innovation platform that will kick off in 2021. It will look at people whose body mass index is within the obese range, appropriately adjusted for ethnicity, who have one of two additional comorbidities, either type 2 diabetes or hypertension or both. And so that will kick off fairly soon in the next few months. But you're absolutely right. We know there was an announcement. I think additional focus beyond what we stated we do in the long-term plan came through COVID, as we'll be aware. Obesity appears to be an independent risk factor for the poorer outcomes of COVID, and that got a lot of spotlight, I think, culminating in a number 10 prime ministerial announcement in July that there would be more done in the obesity space, and that does provide opportunities moving forward. We've talked about the infrastructure. And that's the long preamble, isn't it, to answer your question. But we've talked about and thought about the infrastructure and what's worked well over the last X years and what perhaps hasn't. We've had this tier structure, which has been complex. One of the first things I had to do in 2013 was to try and disentangle who was responsible from a commissioning perspective for which tiers and who was responsible for commissioning tier 3. Was it local authorities or was it CCGs? It turned out to be, CCGs, and that's been established now. But yeah, we have some concerns about the tier structure, perhaps some inflexibility. And I think Partha beautifully articulated it actually in a BMJ blog a couple of months ago, Partha, 2 or 3 months ago, that we're interested in exploring or at least piloting, and this is in the exploratory strategic phase, if you see what I mean, of having a sort of more specialist weight management end of the pathway that differentiates a little less between what we'd currently call tier 3 and what we'd currently call tier 4. And there's some duplication there in terms of clinical psychology support. You're requiring that in tier 3 and tier 4, whereas if they were blurred a bit, it could be much the same team delivering that. And the concept being that if you're landing in a specialist weight management service, there may be a number of options that you could be pointed towards. Therapeutic options, and you've mentioned a nice technology appraisal that's recently been approved. Low-calorie diets may be on the menu. Some may require more fast tracking to bariatric surgery. Some may require much more sort of psychological support over a longer period of time. And so we're very interested in exploring that, but it's very much in the exploratory phase at this point. I hope that answers the question a little.
Yeah, no, that's really good. Because I think a lot of the time on social media, the techie sort of type 1 stuff sort of takes over. And so it's nice to hear what's sort of happening in that area. So that's great, thank you.
Have you ever tried the diet, Jonathan? The low calorie, very low calorie diet?
I have not done 3 months of low calorie diet, I have to admit, no. But we've had a lot of conversations with people in terms of the sort of part of the engagement exercise in preparing for rollout and indeed sort of subsequent to initiation. And the surprising thing is the positivity with people. It's not for everybody. And I don't think any of the options that we present as part of the national programme are for everybody. And I think the important thing is that we have a good portfolio of interventions and appreciate that certain approaches will suit some people very well and others not. And I think even in the sort of cardinal trial, Roy Taylor and Mike Lean's direct trial, I think I'm right in saying that about only about something like a quarter or a third of those approached to take part wanted to take part. So I think let's bear that in mind, that this is not a universal solution to anything, but it will be, a good intervention for some people. But those that have chosen to go on it, the concept of total meal replacements for 3 months is daunting, I think, to all of us. But it's surprising the positivity, and obviously it's not just a matter of replacing all your meals. It's actually a whole wrapped around package of care that goes on for a whole year. The total meal replacement aspect is just the first 3 months. Then there's support to reintroduce meals, and then there's support to maintain the weight loss that you've achieved in those early phases. And so there's a whole package of psychological, behavioral sort of tips to support that. And the positivity with people who are retained on programme is really quite marked and impressive, actually. So if you talk to a lot of people who've completed it, and I'm talking about people that may have gone through, for example, the direct trial, or others that have gone through similar interventions. The Oxford group have done the droplet trial as well, are very positive, actually. So no, I can't. Apologies, I haven't done the 3 month diet.
No,
but,
I've just done it for the last 4 weeks. So it's hard. It's really hard. But I've lost 12 pounds, so I'm really like, it's good. It works.
Yeah.
In her psychological support as well, which has not been fun.
My psychological support, yes. I'm starving. So that kind of brings us on to psychology. Somebody has put on Facebook, what are your thoughts around the lack of psychology support within services, particularly community diabetes?
Partha, you go.
I'll take a little bit of that. So I think one of the things that we are looking at, Diabetes UK have done a piece of work looking at mental health support. There are a couple of things. I think if you talk to any psychologist out there, there's not enough psychologists. So I think we need to get away from the whole belief that all we need is psychologists, because when you put out job adverts, it's not like psychologists are out there in abundance that they're going to run towards it, right? But I think what would be quite good is to look at how do we try and also help other professionals understand the mental health support that people need, right? So identifying those. So we've got established IAP programs around the country with appreciation. That's not the end all and be all. And I am really being impressed by what I saw in the NEEDS program, Northeast Essex, where they've used a bit of transformation funds to dovetail in the IAP to create a psychology support, which is across the whole area, community or acute. Now that's the way to go, where the role of the psychologist is not just to see patients, it's also to educate everybody else, because I'm not saying all of us who are clinicians just in the diabetes sphere are psychologists, but there are some things that we could do without just putting our hands up and going, oh my God, they seem just upset, I'm not going to deal with that. So I think their program has been quite interesting. They actually won one of the QIC awards on the mental health aspect. And that is a really good example of how to use, sparse psychology time for good input into that side of things. And I think some of it comes from a belief in, in the course of time, we'll be looking at this data. So at the moment, me and Jonathan, our team are looking at data around admissions and DKA and all sorts of stuff, as well as good examples in, let's say, young adults, because people say, what we need is psychology services in young adult services. The good centers which do well, it's not necessarily because of the psychology. I'm not saying they don't have a role, they've got a big role, but it's also the presence of actually youth workers and social care workers that's made the bigger differences. Because simple things like, and I'll give you one example, which I always do say, is this particular person, and they won't mind because it's being said with permission for everybody who gets, worried about patient cases being used. This person kept on getting admitted, and they thought, oh, maybe he's got a psychology problem. Maybe he's got. It wasn't. It was because the council had put this young chap in a estate apartment, but it didn't have a fridge. So he didn't have any insulin, or the one insulin that he used was just outside. So he kept it. So it wasn't that he wasn't giving his insulin, he was just giving insulin that didn't work. So it's as simple a thing as that, and a good, well-connected social work would be able to pick that up to say, actually, yes, if we want to house him, we need to get a fridge in his house because he needs that for it. It's as simplistic as that. And I can't tell you how much time was spent trying to send this young guy to a psychologist and everybody else, and the judgment that, he's just a young kid, he doesn't love his diabetes. It wasn't. And he kept on saying, I'm taking my insulin. We're going, yeah, you're not really. You need some mental health support. And he's going like, no. So simple things like that. I know it's an anecdote, but I think that would be my answer to it. We need a more team approach to that. So to the question, should we have more psychology support? I would encourage everybody to look at what the North Essex team has done, which I think is really good about using time. And I think that's something to sort of then go and have those conversations in the local areas to see what can be done.
Mm. There's a question popped up here in terms, my daughter is 20 and diagnosed 5 years ago. Fantastic paediatric care from May NG, way up May. She moved to adults 2 years ago. The DSN services run by Virgin Care. We don't even know who our DSN is. We've been told we can only ring if we have significant problems. What are your thoughts on that? So I think it's about transition from pediatrics to adults. What are your thoughts in terms of that, not specifically that team?
I mean, that was a big part of the GIRFT work. So Partha, do you want to give a little bit on that?
Yeah, so me and Jonathan are very strongly aligned on this one as a big area of focus going forward. This is going to be a big, not just for type 1, if I'm very honest, it's also for type 2 because of the high risks of those group. So I think you'll probably see a fair few things, what we are trying to put now, ideas together as to what we do with this area. I think that, GERF report clearly states that every area needs to have a transition service. You can't have a hospital which has got pediatrics and no transition services. There'll be bits on that. There's a type 1 diabetes audit coming up for the adult sector, which will cover all these, including young adults. Lots of data sets coming out. So all I can say is that the point being made is absolutely right, but there's also some amazingly good young adult service and transition services around the country. And I always give examples of, for example, the Guys team, the Liverpool team, as you all know, Reza and others doing great work. We have the team in Poole with some good evidence. A lot of it dependent on relationships as well between the pediatricians and the adults. That's a fundamental part of that as well. So, and I think that's what I have learned in the national role. So when I started off, and when you're outside this sphere, you always believe, and I used to believe that when I was in Portsmouth, what we need is NHS England just giving us more money. You give us more money, we'll sort it. And I can tell you, after doing this, the answer to that is it isn't. I categorically can tell you it isn't. The number of times I would sit in my office before I took on this role and I said, Dad, Jonathan, what he needs to do, because Jonathan, when did you start? 2012, wasn't it?
13.
Yeah. I remember sitting in my office saying to her, I just don't understand this national team. If they just gave us more money, we would have solved it. It wasn't. And I can tell you it isn't. And that's been our experience of GERF. It's been extremely eye-opening. And I think we are sometimes in a slight bubble ourselves. Because if you think of the people we interact with, we meet in conferences, we talk to, come to meetings, are all the passionate ones, aren't they? Because they want to make those changes. And more often than not, they're doing the changes in their regions. They are badgering their CCGs, are on the back of their clinicians, their chief execs, and they're doing that. So to the question, yes, it is an area of focus from us in NHS England, and we rest assured we will be picking this up as an area going forward.
Yeah.
Sorry, Jonathan.
We, as the national team, we've got to think very carefully as to how we add value to the system in a way. And obviously a lot is based on local leadership, championing, and there are some fantastic models of paediatric services joined up with transition, flowing seamlessly into adult services. There are challenges around the transition years. I've ran a transition service for many years, and young people move around, and so you do your best to get that sort of integration, so that the young person has met the adult team and feels more comfortable with the adult team, but then moves to a different part of the country for university. So there are a lot of challenges in this space, and there are examples of excellent practice. We, as Part has alluded to, there are certain groups that we would very much like to see where there are the clear challenges and problem areas that we want to add value in some way. One is there is clearly a disengaged portion of young people in the transition years who we're struggling to reach, irrespective of quality of service. They're not attending, they're not engaging. Those are the groups often that are in and out with diabetic ketoacidosis at real risk of both the long-term complications, but also the acute sort of metabolic problems that could end in disaster. And so, as Parth has alluded to, we're exploring how we might add value there. And also in the young person space, I think for all of us in the field, one of the things, if you ask me what I'm really worried about in terms of the sky falling on our head, perhaps in 10 years, and we will do our best to ensure that that doesn't happen, is that we're seeing younger and younger onset of type 2 diabetes, but the type 2 diabetes that we're seeing diagnosed at the age of 22 or in 20s or early 30s seems to be a far more aggressive form, with much more rapid progression to kidney manifestations and even cardiovascular disease in midlife. So those are two areas. Interestingly, Partha and I with the team had a strategy day only this week, which we do on a reasonably regular basis with Diabetes UK and etc. to really drill down to how we can, in terms of our next chapters, as it were, in terms of work streams, where could we really meaningfully add value? And so I think that's one of the spaces that we're looking. So Yeah, I think a really important area. Thank you for the question. Sorry, we've gone off a bit in multiple directions there, not gone well beyond the specific question, but hopefully that's helpful.
That's okay. So we've got quite a few clinical questions in on Facebook, so we're not going to be able to answer those ones because they're specific clinical questions. But thank you for putting those in there. If you've got any general questions, then we'll answer those. We've probably got about 10 minutes to wrap up. There's a few things. I think Tamsin had one that had come through. Do you want to read out the question, Tamsin?
Yeah, so on Facebook somebody's asked about whether the ACR test will be added back in onto the quaff data.
So quaff has undergone a number of changes over the years, and I'm the first, I think we both are, aren't we, Path, to recognise the value that it's brought. We have, how do I term it? We've cornered probably 15% of all of the monies that go into quaff. So a proportion of GP earnings is linked to what they call pay for performance. That is quaff. Within quaff, about at least 15% of those earnings are linked to diabetes metrics. And it is a very powerful way of, I'm going to say levelling up, because actually a lot of our community, a lot of our patients are good at ensuring that they get their annual reviews. They will attend when they get the invitation letter to the annual review. What quaff monies do is enable GPs to chase the people that are much more difficult to engage with and who don't access services as well for various reasons, more vulnerable parts of the population. So it gives general practices that resource to go out to sort of persistently chase people and try to get them in. And it's worked phenomenally well. And if you look at the ways in which, let's say, delivery of the care processes has been achieved over the 17 years of quaff, it's really narrowed up. I mean, actually, the determinants, surprisingly, there's very little of the difference, and the variation is attributable to socioeconomic factors, for example. And that's because of the value of quaff in terms of levelling up. Now, obviously, along those lines, we'd like as much in quaff as we can get, but there's a lot of pull on quaff as a resource. And we had urinary albumin to creatinine ratio in, and we lost it in April of 15 when, and this goes well beyond diabetes, when there was, I think a legitimate push to look at care planning, global care planning for people, I think it was over the age of 70 or 75. And so some of the other parts of quaff were stripped out to support pay for performance around holistic care for more elderly people. And I think we have to accept that we're not an island in diabetes. And actually, a lot of people, for example, over the age of 70 have diabetes as well and need that more holistic care. And so, we lost some of quaff, one bit of which was the urinary albumin to creatinine ratio. Now, again, how do we as a national team add value, and which are the battles worth fighting because we might win? I actually don't think that that's a battle at this point in time that we would win in terms of, so the net movement is to evolve quaff into different ways, quality improvement work, which has, if you speak to our GP colleagues, they have very clear ideas of how quaff might evolve advantageously for the whole population. And it does go beyond diabetes. And yes, I'd love to have that in quaff, but we lost it. And do I think we could battle to get it back in? I don't think so, unfortunately. But I think we'll see quaff evolve in many ways around quality improvement and perhaps taking directions that aren't the traditional single metric year-on-year pattern that we've seen in the past. So yeah,
I'm just going to add a few lines to it. I mean, I would say that the important thing, which I always say to, and this is also, again, I think this is why I do believe that a lot of clinicians need to have a stint in some sort of wider role, not just their clinical role. And I'll tell you why, because I think that I've realized and more appreciated what our GP colleagues and practice nurses do. It's very easy for us as a specialist team to say, do this, do that. And quaff is not the, ACR is not the only thing on our desk. We also get these requests, quite understandable requests from pregnancy colleagues. So why isn't preconception counseling in there? Why isn't this in there? So every area will want their bit in there. And I think we need to be, as Jonathan may be very careful as to what we're asking for our primary colleagues to do, because at the end of the day, they do deliver 95% of the diabetes care for us, if that makes sense, for our page, and do a very good job at it across the board. Plus, I think the other thing is this is not the time anyway. At the moment, you know, trying to get anything into quaff when we are asking our GP colleagues to basically front vaccine program for the rest of the country, it's not even going to be on the table. Let's be very, very honest. What about the future? Well, the future is who knows where things settle down, where we are, and we can always debate to discuss it. But for example, we were very successful in getting quaff changed based on frailty, which I think was a massive piece of work. We were the first country in the world to go like, okay, we're going to get an HbA1c in there, cholesterol, blood pressure, which was really good piece of work, working with NICE, and Jonathan led that piece of work with negotiations with our BMA GP colleagues are never easy, and that's their job too. I'm not critical of them. That's their job to try and fight their corner. So it will need a lot of effort and a lot of work, but at the moment is not the time while we are trying to battle our way out of a pandemic, and our GP colleagues pretty much front and center of that work. So, and I finally will always say, and this is what I say to my clinical, because I've had this question a number of times, why isn't ACR in there? My question straight away back to them is, what would you like us to drop? That's my first question. So rather than add on, what do you want us to drop? What do I go back and say to our GP? Stop doing that. And the answer inevitably is, oh, no, we're not going to stop anything. We're going to add things. And that's not an easy ask of our primary care colleagues. So I think that's my always return back. What would you like our primary colleagues not to do that they do in present care? Then we shall see. But there we are.
I think we've got time for one more question, Beth, that I think it leads on from the quaff conversation.
Yeah, it's kind of just to follow on really. So it says, can I ask about the recording of people attending type 2 structured education, as currently this is not incentivized and the numbers are low. This person's own data shows 60-70% attendance versus 5% from the quaff National Diabetes Audit data. So is there any work going to be going into looking at that?
So I think this again relates to I think you talked about incentivizing recording. Is that the wording you use, Beth?
Yeah.
And that links to quaff. Yes, the quaff metric about structured education is offering of referral to, I think, and we know that you know, the attendance is not recorded well at general practice level, but you know, again, I think this links very much to the last bit and to what Partha said. What we have achieved in diabetes care is huge over the last 17 years, and much of that links to the huge amount of work delivered by our primary care colleagues. Some of that has been supported by quaff and some hasn't. But you know, we have achieved huge things through the focus on diabetes and the fact that, 85-90% of care is delivered out of general practice, and we mustn't forget that. Quite understandably, what the activity that doesn't take place in general practice is not recorded that well on general practice systems. That would be the same for my system in my own clinic. I'm not necessarily transposing someone else's clinic activity onto an electronic data set. I'm recording my own data. And so much of this is effective linkage of IT systems. But what we are looking to do, and what we've done successfully in our new programs, obviously some of the new programs that we've started, and again, you know, type 2 diabetes prevention program would be a cardinal example. There was no, you know, we have put out there a new service nationally, but part of the mechanisms is that all of the providers have to provide us with data, very granular data of everyone passing through the system. And we have the ability to link via the NHS number and an identifier with the National Diabetes Audit, for example. So we can link. And so I think there's real scope for taking the activity that we know is going on in terms of the provision of structured education, and instead of asking our general practice colleagues who are being asked to do everything at the moment to transpose a bit of coding in their own system, I think what we need to get to the position of is that our providers of structured education link via the National Diabetes Audit data to populate the data set so that we can see that 60% in that area have had their structured education. So we are making big strides in that space. And I think that has come from initially some of the newer work streams, but will undoubtedly roll forward onto, and also Parth has alluded to the type 1 diabetes audit module that will be coming online soon. And again, that is, you know, often much of the, let's say, care processes that have taken place for an individual with type 1 diabetes. They attend a specialist service. Care process delivery has happened in the secondary care environment, hasn't been recorded well in the primary care environment. And so it might appear on the GP extracts that that care process hasn't happened, but it has. It's happened in a different environment. And I think by merging and linking data sets, which we're getting much better at, and again, COVID has broken down some of the barriers around data linkage, which will provide opportunities for us moving forward. I think we can get much truer pictures of who's had what. And I think, Beth, that's fundamentally what your question is.
Yeah.
Correct?
Yeah, I'm just going to add a couple of words to it. One is, I think we shouldn't forget also, and this is I discovered while doing the Libra thing, the legal side of it. We can ask a person with diabetes to attend. We can't force them to finish it. Okay, this is a fundamental thing we need to remember. We can't say to people, you have to do this, right? We can't force them. Nobody can force anybody to do anything. Okay. So I think the recording bit, and I think what I say now because we've got a large expansion of digital things coming through, do we now expand it to so the people who have finished the program themselves can let somehow the NDA team know so we can pick up that they're finishing it, the provider's doing it. So I think the opportunities are really there. But I think that's something which goes back to what I always discuss about the whole issue around technology and pumps, that you have to attend this. And if you don't finish this, you will not get that. NICE has never said that. People need to be careful about the interpretation because it's open to challenge. And you cannot force anybody to do anything, you know, because that's how it is. So, yeah.
In Kent, we've just got an education hub for the whole of Kent. So anyone in any of the different CCGs can refer into one hub and they can go anywhere in Kent. So if they work in Medway, say, but they live in Dover, they can do their education in a different area and it'll still get marked on the audit because it's being done centrally by a hub.
That's great.
So that's making it a lot more. So I think we need to kind of wrap up. So I just want to ask the question to Jonathan first. You've been in NHS England for 8 years. What is your proudest moment?
I think one of the, I think high level, proudest thing is that we've got to where we've got to. We've got such a broad portfolio with such a fantastic dedicated team that touches most aspects of life, I hope, for the diabetes community and those at risk of diabetes as well. I'm really proud of how things have evolved over the last 8 years. That's my top line. The individual thing, I guess on a personal level and from our first work stream within the national programme was, of course, the National Type 2 Diabetes Prevention Programme. And, you know, much of what's happened in that programme, certainly some of it is world first. And, you know, we've got lovely outputs and data that we've published in high impact journals that have made, you know, made people take notice of achievements. But more importantly, I think, yeah, we've got a high proportion of the population with diabetes now, and there is, I hope, real opportunity to stop that inexorable rise of prevalence of type 2 diabetes. We've also got mechanisms in place if opportunities around type 1 diabetes prevention reveal themselves in the years to come. You know, I'd love to think that we would run with that too, and there are infrastructures in place with things like the address study that have paved the way for that if opportunities arise and interventions arise to prevent type 1 diabetes. But I think the single work stream that I've been doing for the longest and I think I'm really proud of is the type 2 diabetes prevention programme.
Partha, how long have you been in NHS England? 4 or 5 years now, is it? Or
4 years, I think. 4 years.
4 years. And what's your proudest moment in those 4 years?
So I think I'll probably give it answer just like Jonathan has done. So I think proud would be being part of this team because, and I don't say that glibly, because to be in a position, I never thought I would be in a position in my career that you'd be in a space where you can influence lots of other people's lives. That's the honest answer. You get to the pinnacle of being a consultant in our lives and you think you can do it for your locality, and that's about it. To get to this at this stage of my career, I wasn't expecting to get here. Jonathan asked me to join the team. And I think over the course of time, me and Jonathan become very good friends. So that's a very good, proud moment. I think, we sound each other off, and it's been a great partnership, and we've become very good friends over the course of time, to the extent that we always go like, when is the lockdown lifting so we can have a beer? That sort of conversation always goes on. I think singular would be, I'm not going to pick one. People always expect me to say Libra. It isn't, actually. I think the most proud moment for me is managing to get type 1 diabetes on the map of every single area. It's a conversation topic. I'm not saying we've solved it by any means whatsoever, but I think getting it in the conversation probably would be my proudest moment. So everybody knows that Partha will be snapping if you haven't got a plan for type 1 diabetes. So I think that's probably the proudest moment, I would say.
Yeah, that's lovely. All right, I think that just about wraps it up. I'm
going to say something actually before we wrap it up, because I think I'm going to say this on behalf of me and Jonathan, because we say this all the time. And I think, first of all, I'm going to say thank you to you guys in the DSN forum, because I think you guys have been doing some absolutely brilliant work, raising the morale of people, and also doing all the stuff that you do, specialist nurse colleagues or any other nurse colleagues. And I think to anybody listening and those who listen to the recording later, me and Jonathan always use platforms to say thank you to all the staff in the NHS for what you've done. This has been an extraordinary year. And if you look at, feedback across the board from social media or any other media or things we get, there are lots of areas struggling. Diabetes is no different, but in general, you can see that lots of people have had some degree of support from clinicians, locally or otherwise. And I think it's just a forum to say thank you to everybody for all the hard work, which is hugely appreciated.
Absolutely.
Yeah.
Thank you, everybody. I think it's been a really challenging time, and the way in which the healthcare professionals generally have supported people with diabetes, but the whole population really, I think is something to be really proud of, and thank you to everybody.
Yeah, a big thank you to you guys, because I think clinically, I think we feel quite supported by you guys as well, and I'm not sure any other specialty has, like, their specialty directors have such a presence in their kind of specialty. So I think we're quite lucky in diabetes. We feel like a big team.
Definitely.
Especially in 101. All right, I think we're going to end it there. Thank you very much for spending your Saturday morning with us, and we will see you in January for our next one, where we will be interviewing Trend and talking all about diabetes specialist nursing. So until then, see you later.
Thanks all.
Bye-bye.